Hello, happy lunchtime, everyone. Welcome back if you were with us yesterday, and if you weren't, we missed you. Yesterday, we really talked about, kind of outlined the commitment of DHCS to improving the health and well-being of the Medi-Cal members. And we talked about the what I like to call the overarching umbrella of sorry, I'm trying to fix a Zoom thing here. Just bear with me a second. So I talked about kind of the umbrella of Medi-Cal transformation. And we took a small part of that and dove into CalAIM, and we broke it down. And it's not such a burly thing after all, if you break it down a little bit. And then I really feel as though the A and the I gets buried in CalAIM, and this is really about advancing healthcare service delivery and innovating healthcare service delivery. And I keep thinking, like, how can we do that as part of PATH? And so for today, well, let me back up a bit. So on our Zoom poll, we had a couple of kind of thoughts about more information. Somebody mentioned more slides on the TA marketplace. So if we have time, I'm happy to kind of answer any questions anyone has about TA marketplace that I may or may not be able to answer. And then someone mentioned about getting more concrete about accessing resources. And if one of you submitted that and you would, I'm not quite sure what that person meant about accessing resources, like accessing cheat sheets and things like that, or actually connecting Medi-Cal members with resources. I wasn't quite sure, and I apologize for not understanding what that was, but we can, if we get through some of this, we can have some time to chat about things. Again, the HIP team is comprised of Berenice, Maria, Maritza, and myself, and we are a trusted advisor in Santa Cruz County. We work with so many organizations. I think we might even have a shorter list of organizations we have not worked with. And then we have this reputation for making things happen. And sometimes that's why people kind of engage us to get work done. And we just love that about us. If something is underlined in the slides, it's a link to a resource. So when you get the PDF or the link to the full set of slides, those links, you can go to those links for additional information if you like. And we will send the materials and the recordings for all 3 sessions. And we encourage you to take and use any of the slide content that you see worthy and use or brand as you see fit. Firm believer in steal shamelessly and share senselessly. And if you have questions, just chat or raise your hand. And then I just want to say again, it's a lot of information with lots of words on slides. It's hard to grasp this. Sometimes people say 7 different times and 7 different ways. I kind of feel like I'm in the group of people who need 14 times and 14 different ways. And again, if we have anything on our slides that's incorrect, please give us a heads up, chat to Maria or Berenice, or chat to all is fine as well. Just a reminder, this is how we kind of laid out the CalAIM PATH initiative, and there are the 2 aligned programs. We covered the Justice Involved Capacity Building Program yesterday, and we also covered the support for implementation of ECM and community supports. And today we're going to take a little bit of a deeper dive into the PATH collaboratives and then also into ECM and community supports. And you'll note that throughout our slides, we don't use the acronym CS, and that's because DHCS has sent the messaging that they would prefer that we not abbreviate community supports as CS. So we, throughout, I think all of our material today, we spell it out. And if you're wondering why in the world do they not just shorten things, that's why. So the PATH collaboratives were formed using a kind of funding to provide funding for county and regional collaborative planning efforts to support implementation of ECM and community supports. So I didn't just not abbreviate it. I forgot to add the supports part, so I will fix that when we get through. And you may remember that I talked yesterday that there are 26 regions and there are 10 different facilitators. And for joining the collaboratives, we really want CBOs, we want our county, city, and local government agencies, we want our community health centers. Of course, as you know, we have our 3 community health centers in Santa Cruz County. We have Salud para la Gente, Santa Cruz Community Health, and our county clinics. Our managed care plans, which we have, are 2. So we have Kaiser Permanente and we have the Central California Alliance for Health, probably heretofore referred to as the Alliance. A Medi-Cal Tribal and designee of an Indian Health Program. I'm not sure that we have any of those in our collaborative. And then providers. And it's not just limited to hospitals and provider organizations, and then others that are approved by DHCS. I will say that in our collaborative, we've kind of let anybody in who's asked. We haven't been too stingy with that, and have just been people say, hey, can I join the collaborative? We send them the registration link and we say, okay, do it. So I'm gonna zip through these slides, but this is a little bit of a looking behind the scenes at Disney. So what does the PATH Collaborative actually do? What do we have to do? What does DHCS and our third-party administrator, the public consulting group, require that we do? So we have to provide monthly meetings, at least an hour. And we kind of settled on an hour and a half. We found that an hour was just not quite long enough. So we went with an hour and a half. For 2024, we are required to have 2 to 4 in-person convenings. And so we have identified that we will have 3.5 hour in-person meetings. Our previous in-person meeting was on October 18th, and I think that was 2.5 hours. And folks told us that it just wasn't long enough. They really enjoyed talking with each other and networking. I heard so much sharing of information. I went around and I just kind of lurked, eavesdropped, whatever you want to call it. And it was amazing, the sharing that went on and the connections that were made. I actually saw business cards being shared. We are going to have to, for 2024, facilitate and drop-in office hours. And I think our area, our region is a little bit different because our managed care plan, the Alliance, and I have full expectations that Kaiser is going to be as awesome. They already have office hours. And so if we have office hours, we're kind of duplicating it. Although I do think that this might provide some time to provide some guidance or coaching or do a TA marketplace tutorial or something like that. So, we're still sorting out how to do this without adding one more meeting in everybody's calendar. We have considered adding it on to the end of our monthly meetings for people to stay. RF, we definitely aim to be awesome. Oh my gosh, I think I need a screenshot of that chat. That's hilarious. And we have also, the Camden Coalition is kind of our sibling PATH facilitator because they cover San Benito, Monterey, and Merced, which is also covered by the Alliance. And, it just might be economies of effort if we kind of join with the Camden Coalition. And we have to develop convening work groups based on what the needs of our participants are. And we initiated very, very early in January, the Enhanced Care Management and Community Supports work group meetings, which have been really great. I will say when we go over the community supports, if you're not already well-versed in it, and I expect most of you on this call are, you'll notice that a conversation with people who are providing housing supports versus medically tailored meals I need to have 2 different conversations. So the community supports work group meetings are usually broken up. So they have breakout meetings and then they come back together. And then there's just more and more talk about data sharing and measurement. And I have a feeling that at some point or another, we might have to resurrect the data sharing work group. So we had the data sharing work group early in the year. They met once and they kind of bookmarked and put a pin in several issues, and there was no sense to continue the work group meeting anymore. More than you ever want to know, but just know that there's some organization behind our activities. We early in 2023, and then we've made modifications as we've learned more about our system of ECM and community supports delivery. We had to develop a project charter, aim statement, key driver diagram, which you all may remember. We tried to get feedback way back in January about the drivers, and we'll just really quickly show you what the driver diagram looks like now. And it is a much better fit for what is actually going to drive ECM and community supports, implementation and sustainability. We have to have a recruitment strategy. How do we keep people and how do we engage folks? Who else should we be inviting to the collab? We need to have a work plan and budget, of course. My favorite quote from Yogi Berra is, if you don't know where you're going, you'll wind up someplace else. So having a work plan and knowing how much it's going to cost you to get to your accomplishments is a good thing. And then we have to submit these really burly quarterly reports. They're massive Excel spreadsheets with 15 tabs, and there's just a ton of information. But this is how the public consulting group has to feed kind of back up to DHCS if they are investing all of this money. You know, if I were in DHCS's shoes, thankfully I'm not, I would want to know if we're investing millions and millions, $1.85 billion, like what's the return on the investment here, guys? So, you know, we have to kind of reflect that back in our reports. I'm just going to go through these really quickly. These are basically from our agreement that we have had to sign. So we always have our ear to the ground and let you know what's going on. We track organizational improvements and tests of change. Tests of change is terminology that is used by DHCS and PCG all the time. And I think some people have different ideas about what it means. And if we were just kind of, I think when we say tests of change, what people might hear is wah, wah, wah. But what it really is it's something you've identified that there's an opportunity to improve, and you think, oh, well, let's do this change. That's a test of change. Or even just doing a plan, do, study, act. So you identify, oh, this is a great change, we think, but let's test it out on a small scale. And then if it works, then, you know, let's expand it or abandon it because it was a terrible idea of a change, or we need to adapt it. Get subject matter experts whenever we can, and we've done that during the year. We had Kitty Bailey from the San Diego Neighborhood Network, which I think was probably one of our best subject matter experts. We also confer with her on the practice grant activities. Teach and coach participants on quality and process improvement principles, including all those other things listed. So we've been doing one-on-one real-time process mapping with practices and CBOs that are interested in kind of having some help with that. We did the Charting Your Path QI series. We're probably going to have to resurrect that and redo that training. More about tests of change, support creation of and contribute to a best practice library. So we have that to a certain extent, but I think we have some work to do. And when we collate all of the responses from our listening sessions, we will have that best practice library. So, you know, for example, measuring. So we've been talking to community supports providers and ECM providers, and we say, well, what are you measuring? You know, because if you don't, you know, how do you know that if you're providing ECM or you're providing community supports that you're making a difference? So if you're providing ECM, are you helping patients stay out of the emergency department and being admitted to the hospital? If you're providing medically tailored meals, are you are you seeing, less utilization? True, but are you seeing better diabetes control because you're tracking their A1C test over time? We have to administer participant experience surveys, and you will see that in the next biweekly update. We have to do that twice a year. And then we also have to provide feedback to PCG, which gets fed back up to DHCS on how we think they're doing as the third-party administrator. We have to support dissemination of other path initiatives. We do that quite a bit. Promote awareness of DHCS education and knowledge that is available, which we do in our biweekly updates. We meet with PCG. They've been great. We really appreciate checking in with them. We have to attend meetings, including those that are in person. So we attended the one earlier in the year and the one November 8th. That was great, great, great. And then there's this other bucket. And these kind of come out of the blue a little bit for us, progress reports, or they, we've asked you, we've said, hey, DHCS wants to know XYZ, and we have to put it together and send it back. And that's kind of those progress reports and collaborative updates that are in the bucket of, well, we don't really have this sorted, but we've realized that there's a need for this information. So the resources and best practices library, we started like right out of the gate, starting to collect resources. And we are going to publish them on the HIP website in 2024. Lynn Lordson from the county emailed yesterday, I think it was, and asked something about a resource document. And I think that's what she was talking about. And if anyone is, and so we're going to clean it up. And I just need to make sure that all of the resources that we put in these slides are actually in our resource document. If you would like a copy of that, it's a lot. We're happy to send it out. We have thought that and Paola Luna, who kind of started with the Path Collaborative, kind of put together a training. Like if you want to just start somebody on learning about CalAIM, what are the resources that you need to have? But if you want a copy of those resources, we're happy to send them out. I think what we can do is share the link and send the link in our follow-up. Listening sessions, we've just done a lot of listening and learning. And what it has enabled us to do is that when we talk to our ECM or community supports providers, like we were talking to Santa Cruz Community Health yesterday, and we could say, oh, well, so-and-so is using Activate Care in this way, and here's what their frustration is, or so-and-so is measuring their time for their care managers in active one-on-one contact with their members. So, just sharing, hey, did you know so-and-so is doing this or so-and-so is doing that? We were also able to connect Modify Health with Dorothy's. And then I think Encompass also joined to kind of talk about Office Ally, which is a clearinghouse option that is free. Just kind of knowing who's doing what has been huge for us to identify, like, how exactly can we help you? We are happy to help with, putting together the cited to or TA marketplace grants. When we were talking to Emily at SCCH, they have a really good system internally and they just don't need any help. They're on it. We're, doing the Charting Your Path series. If there's a segment that you would like us to put together, just let us know. The FAQs, I think we discussed yesterday. Those have been really helpful because when we go to the office hours, we hear things over and over again, like that for the ECM providers, they get a spreadsheet of members without claims. And it seems like at least once a month, somebody asks the question, like, what am I supposed to do with this? So we have we created an FAQ around it. We meet with other stakeholders. So we meet on a monthly basis with the Alliance. That is a meeting also with Camden Coalition, and it's really helpful. I will say that we usually put together an agenda of things we want to talk to them about that is just too long to get through in a half an hour. And then we have our other meetings. So, taking AIM, we kind of struggled at the beginning of the collaborative because we weren't quite sure how could we write an AIM statement that was really a SMART AIM, so specific, measurable, actionable, realistic, and time-bound, if we weren't sure of the data source. And so we had one that was just kind of just a little mushy and lofty, but not realistic, and we couldn't really get data for it. So we've kind of massaged it to where it is now, because on a quarterly basis, the managed care plans have to submit this data to DHCS, and DHCS is shortly going to be facilitating our receiving more of the data that the managed care plans submit to DHCS, which is like a ginormous hallelujah, let me just say. And so we want to increase the ECM uptake rate from 0.5 to 2.5%. So Santa Cruz County was a little low compared to some other counties with the uptake of ECM, and the uptake of ECM is at the end of December 2022, there were about 78,000 members. And so it's basically the percent of those members who are receiving ECM. So we're never going to have something like a percentage that's 25%, because you would not expect 25% of Medicaid beneficiaries to require ECM. It is, and you'll probably hear me say this statistic again, but approximately 5% of the highest risk patients account for 50% of the expenditures for both Medicaid, Medicare, and Medicaid. So I would not expect that to be more than 5%, because there are other ways that members can receive care management services. Really quickly, these are our primary drivers. So if we truly want to get to that aim of connecting more people, because basically our aim is if more people are connected to ECM and community supports, that percentage will go up. So if we truly are focused on that as our aim, we need to get more ECM and CS providers or increase their capacity, right? Support those already. Oh my gosh, we do have an abbreviation for CS. Okay, I lied. We have to support those who are already providing ECM and community supports. Through our listening sessions, we have had a peek into the world of those providers, and it is so much work. It is a ton of work. When we were talking to an ECM provider the other day, we were talking about reimbursement rates and so on and so forth. And they said, you know what, this is not a money-making venture. We are basically breaking even. And we have heard from our community supports providers that without additional funding, they're not sure that they're going to be able to continue providing community supports. It is a lot of work, let me just say. And then connecting members with ECM and community support. So we'll talk a little bit more about this tomorrow for those of you that can join us. Like, how do we leverage our network of care in Santa Cruz County to identify and connect people who should be connected with ECM and community supports? And then we have these secondary drivers that are like, if you want to onboard new ECM and community supports providers, what are kind of the secondary drivers for each of our primary drivers? So to onboard new ones, we need to identify like who could potentially become a provider. And then we have to provide the support to help them onboard. And we've done that a lot, it's outside of our listening sessions, but our team member, Maritza, will often let us know, hey, you need to talk to so-and-so, they're thinking about signing on. Let's just talk to them about whether this fits in with their current population that they serve. And so there are no doubt secondary drivers, but for each secondary driver, and this is standard kind of nomenclature and structure for a driver diagram. So for each of those secondary drivers, there are tests of change, like what could we do to actually drive the secondary driver that's going to drive the primary driver, that's going to get us to our aim. Again, it's kind of like nesting dolls to me, and this is a lot. I'm not going to go over this, just so you can appreciate, that's the wrong word, just so you can have a peek into the fact that there's a lot of work going on in the background. Okay, so that's it for kind of the Path Collaborative. Now we're going to dive into the details of ECM and community supports. And I think this part of our hour together is going to be a little more interesting. If you have questions about kind of the first part of our hour together, just chat, raise your hand, and let us know. So we're going to take a bit of a dive into the details of ECM and community supports. The details are like, they just go kind of ever deeper. So we're going to take a kind of a high level dive. I guess that's probably like, doesn't quite make sense, but you'll see. So in Santa Cruz County, there are 15 ECM providers and there are 20 community supports providers. That does not mean that those ECM providers or community supports are or need to be in Santa Cruz County. However, I'm going to share an FAQ that we put together because one potential ECM provider asked this question, and we researched it in the policy guide, and then we also reached out to the Alliance, so we'll kind of cover that. So to really drive or kind of fry the ECM and community supports, DHCS has some action plan levers, so standardizing eligibility. So among all of the managed care plans, it needs to be the same. And if you read the policy guides, they both say that, you can't make up your own eligibility criteria. DHCS has said what the eligibility criteria are, and you need to stick with it. You can't kind of stick your own little pet things in there. It is what it is. Increasing referral sources and streamlining processes. We'll talk a little bit more about like, how do we increase those referral sources? So the referrals should not just come from the managed care plan. They say no wrong door, but it shouldn't just be referrals from the managed care plan. There are a lot of our ECM providers that only accept referrals from internally sources. So at least 2 of our ECM providers, their referrals come from internally. So they are a clinic as well. And so those referrals for ECM actually come from the clinic. But, where else? That's a small portion of the people who probably could benefit with and qualify with for ECM and community supports. And the processes are not always streamlined. Let me just say, I think that our managed care plans are doing a pretty good job, but there are still some bumps in the road, things that are annoying, administratively really, really burdensome. So there's that list that I said, members with that have not had claims. So if there's not a claim, they're kind of going to drop out of your cohort of people that you're kind of doing outreach for or have in ECM. And there are a variety of reasons why you might have a member that doesn't have a claim. But when we were talking to one of our ECM providers, they have to allocate 3 different people who have to double check that list and reconcile it with kind of what they are maintaining in their how they kind of track their members and their electronic health record. And so there's this whole reconciliation process when they receive these reports once a month. And it's like, it should be easier. And I think streamlining the processes, like we really want to, yesterday we talked about the importance of integrating care, coordinating care, and yet how is it that we can be seeing a Medi-Cal member and not know whether they are in ECM or are receiving a community support? Like, I just feel like there's got to be a solution to that. Streamlining the authorization process. So, if the authorization process includes a fax, for example, like how is that going to work for people that don't have a fax? Like they can't necessarily receive a fax, they can't send a fax back. Are they, early in the year, there was kind of this conversation about faxing. Well, I don't have like CBOs, like, do they have a fax? Who faxes anymore anyway? You can get the electronic faxes, but, streamlining the authorization, expanding provider networks, like we talked about, streamlining payment. So there's this idea to streamline payment where you have a hub which I wish we could find one in Santa Cruz County. I have a couple of ideas of who I think that should or could be, but what they do is, you kind of join on to the hub and you have your payment, you submit your claim for the services, because that's how you get paid, that's how you stay in business. And then you submit it to the hub pays you immediately, so that you are getting your money immediately. And then they submit the claim up to the managed care plan, and then they eventually get the money, but you get the money in your pocket. Into your system, into your budget. So, the DHCS is pretty keen about this hub model, which, I'm not quite sure how we can pull that off in Santa Cruz County, but if you have any ideas, how to find the Santa Cruz, the HIP team, strengthening market awareness, this is the advancing and the innovating part where I think that we can really kind of double down on. You've heard me probably say several times that, this is street medicine, going to non-traditional places. Like I imagine, so I have this idea about the role that faith-based organizations can have through our work on practice. When we were working with someone around trauma-informed care, and he was talking about in our faith-based organizations, there's a certain percentage that have experienced adverse childhood experiences, and so anyway, I won't go off on that tangent too much, but anyway, I keep thinking, could we at faith-based organizations have like a 1 or a 2 pager for people, just, because we really want referrals from the community, and then improving data exchange, of course, data exchange, data sharing. I think we just need to sort out among ourselves, like what data, and what are we going to measure? So enhanced care management is the service that Medi-Cal is providing. Enhanced care management is not the end all and be all of care management. So it's care management is provided to the highest risk patients. And yet within care management, there's kind of that basic population health management. And that provides care coordination, which is a little bit of a part of care management. And then there's the complex care management, or CCM, and that is for people of higher and rising risk. And then there is those with the highest needs. So those people with truly complex care needs, and who also need health related services like, let's see, housing and food. So, there is this kind of continuum of, who needs what. So enhanced care management is an integral part of the population health management program under CalAIM, and DHCS actually calls it a cornerstone. And having that whole person interdisciplinary approach, so it's not just the primary care clinician, it's not the physician, the PA, the nurse practitioner, but it's truly an interdisciplinary approach. Like I would love it if everyone in somebody who has high complexity, high need, high cost, can they have not case studies, but get together and really have a way to coordinate care. It would be amazing. Maybe one of these days when we truly advance and innovate, and making sure that it's person-centered. Yeah. Okay. So moving on. So, population health management and enhanced care management, like how do they tie together? As I mentioned, stratifying your patient panel. Remember, I talked about primary care being the bedrock of the healthcare system. And you have a panel of patients, the patients that come to see you, they are in your electronic health record. You can assign risk, whatever risk stratification you want, 1 through 3, 1 through 5. 1 is the highest risk. You define what that is. You're able to run a report on all of the people that you see or have been seen in your clinic and do that risk stratification. Some of you may or may not, I have told this story too, but when I was working on a project with low and middle income countries, I was able to go to Mongolia And for their entire population is risk stratified into 5. So, 1 through 5, 5 is the highest risk. And in each of their areas, like kind of like we have counties, they have SUMs. For each household, they identify the highest risk person that's, in a household. And their goal is to make sure that by the time people reach retirement, they are at a very low risk score, because that helps with their health span, so that they're healthy, as they age. So that kind of the 5 arms of population health management that ECM also helps with is the kind of the in-reach side, like when we see them in clinic, or when we have an in-person visit with a member, and we can identify and address any gaps in preventive chronic care, mental health care, emotional health, social drivers of health, those health-related social needs. Outreach, that really is kind of running reports of who's due for what and trying to contact patients. It's a process. And I'll say that when we talk about equity, so when I've worked with the practices in Santa Cruz County around outreach, like who's due for what, and we're going to make phone calls, and we're going to text, and we're going to send them letters, and we're going to try to get them in because they're due for testing or cancer screening or whatever, or a well child exam. The managed care plans provide those reports, and that's what a lot of our clinics use. But what about people who are not covered by Medi-Cal? Like, where are they? Are they kind of, do they fall through the cracks? Our reach, so taking our healthcare services kind of beyond our brick walls, doing risk stratification, identifying those who are the highest risk, and then having enhanced services to support those people. So you can have your own internal care management services that you provide. You can get for Medicare patients or Medicare beneficiaries. You can get reimbursement. Some of the private insurers provide that. And then we know that Medi-Cal has a very robust system for providing enhanced care management. And then there's identifying the social drivers of health. So let's move on. So the goals are improved care coordination, which, oh my gosh, we have so much work to do. Integrating services, we're getting better. Facilitating community resources. Like, how do you even know? Like, we'll talk a little bit about this tomorrow. Like, I at my clinic, we had a cheat sheet with community resources. It was an Excel spreadsheet, and so I asked our nurse manager. I said, how do I get that? And she's like, oh, it's an Excel file on my desktop. Like, that's like, sometimes it is something that is as simple as that, like facilitating community resources. Like, how many people are accessing Santa Cruz County United Way 211 to identify what the community resources are? Like, how do we have that network of care that truly uplifts and supports everyone? So it's not just the same people, the same kind of routes that people take that gets them connected with what they need. Addressing social drivers of health, improving health outcomes. So that is one of the quintuple aim. It used to be the triple aim, then it was the quadruple aim, now it's the quintuple aim. And one of those is improving health outcomes. So, getting diabetes under control, reducing symptoms from depression or anxiety, and then decreasing inappropriate utilization and duplication of services. Like, that is so healthcare centered, right? We talk about having things that are person-centered, inappropriate utilization and duplication of service. So inappropriate utilization, if you talk to patients and you say, hey, why did you go to the emergency department for that? And they say, look, I was afraid and you weren't open. I couldn't reach you. So I went to the emergency department. So we, from the healthcare perspective, call it inappropriate utilization. And I think I would love us to kind of change it. So, I'm just gonna get off. I'm gonna stop talking about that. But I feel as though that kind of calling it inappropriate utilization is not person-centered, and we really talk about person-centered. In Arkansas, Medicaid, if a patient is seen in the emergency department and it's something that the patient could have been seen for in primary care, and the ED visit occurred during primary care hours, the emergency department may not get reimbursed. So there's kind of this payment push to push patients to receiving healthcare services in the lower tiers. So you want somebody to be kind of tier 1, primary care, tier 2 is kind of urgent care, specialty care, and then tier 3 is like inpatient. I will tell you that I love the ECM policy guide. I feel like it is our, dare I use the word Bible, it is our source of truth. It is just really, really well written, comprehensive. It's not all that long either. It's just a really great resource. And for each population of focus, it covers the eligibility criteria, very, very detailed. Back in July, they added the population of focus that were children and youth, which is people who are under the age of 21. They give examples of what a member under this population of focus might look like, and then some operational guidance that is really helpful, including for a particular population of focus, what community supports might be best for that member. So there are 9 populations of focus currently. This used to say adults, and I love that we now have individuals because the pediatric population of focus is included. Birth equity starting in January. That's so exciting. It is limited to certain ethnicities, races, as we mentioned previously. So here's the piece. So there are a lot of models of care management. So you can have your care management program that is within your clinic, and you can call people. The Alliance has their care management program or case management program, and they call. But ECM, DHCS says it is intended to be interdisciplinary, high touch, person-centered, and provided primarily through in-person interactions with members where they live, seek care, and prefer to access services. So, we had one ECM provider who said, look, we want to provide ECM, but can we do it by telehealth? And so we submitted this to Jessica. We already knew what it said in the policy guide, but she kind of said, we already do telephonic case management. Like, why would we pay for you guys to do it? Like, this is supposed to be, higher level. So moving on to community supports. I'm going to pause and take a breath. Case conference. Thank you, Arif. I was struggling. Got too much going on in my head right now. There's a lot of, so let's just group the community supports into 4 buckets. I think it makes it a little easier to digest. So there are community supports that help keep people in their homes. There are ones that address housing issues. There is so much, it's just a simple slide, a couple of bullet points, and it represents so much work. And there's so much work done, and our community supports providers are really kind of trying to make ends meet as they provide these high resource. They have to invest a lot of calls and checking in with members. And there's the housing transition navigation services, which is kind of connecting people with housing. And then housing deposits is a $5,000 once in a lifetime kind of option. There's housing tenancy and sustaining services. We heard one of our housing community supports kind of describe the work that is under there, under that particular community support. And if you want to get somebody housed, you want to keep them, because it is so hard, especially in Santa Cruz County. And if a member will say it's just not working for me, and they said, what we say is, tell us exactly what's not working for you and let's fix it. So that's kind of like what fits under housing tenancy and sustaining. So these interventions are really geared at promoting health and preventing the need for higher intensity services, hence the term in lieu of services. So if we do these kind of 4 buckets, if we kind of address or, keep people in their homes, et cetera, these are in lieu of higher intensity services, higher costs, and you keep wondering why I'm talking about 4 areas. So the other are managing chronic conditions, for and providing safe and supportive environment, safe and supportive environment to become sober. So our sobering center is going to be opening up in Santa Cruz County. We're very happy about that. And, the HCS wants the majority of referrals to be coming from the community. We do not have a robust pipeline right now in Santa Cruz County, and I'm not quite sure how to fix it. So this is the really busy slide of community supports when they're just kind of listed 1 through 14 and they're not put in those 4 buckets. Oops, sorry, I went backwards. So what are some of the challenges? Like what kind of gets in the way? And so Lynn, I see your chat. So our ECM program holds regular case conferencing with community supports providers to discuss shared clients. Like that right there. Remember how we were talking about best practices? Like, oh my gosh, that is exactly right. I got to give that one a heart. Nice job, Lynn. Thank you for all the work that you do and for all that the ECM providers and other community supports providers do as well. You're all amazing. And I'm just in awe at all the work that you get done for helping make a difference in people's lives. So what are the challenges? So aligning beneficiary needs with the model of service delivery and the options that are provided by the managed care plan and its requirements. I know that some of our ECM and community supports providers are kind of struggling, like we don't have an electronic health record, or we have Unite Us, which, partially works for us, but we can't see the other referrals. Skyo is working to fix that. Thank you, Skyo, Dan, and Becky. Activate Care, which there are some frustrations around running reports, integration, duplication of like if we're keeping our records here and then we have to update Activate Care, and then we also have to update Unite Us. So finding a secure way to track members' information and data accurately. We know that at least a few of our ECM providers are looking at implementing a different solution. And so we've said, hey, TA Marketplace, like that is like, exactly where we should be headed. And then developing a revenue cycle management that just is streamlined and easy peasy, and doesn't result in denied claims because I don't know, one little thing in your spreadsheet is wrong, so all of your claims come to a screeching halt. Staffing up and retaining staff. So some of our community supports providers, we've said, look, we're finally at where we should be with staff. But kind of losing staff after you've invested getting them up to speed and then retaining them is just an ongoing issue, especially because there's now kind of competition for the same the same people kind of in Santa Cruz County, making the business case. Very concerned about when I hear ECM providers say, yeah, we're just breaking even, or community support saying, yeah, we're not sure that this is going to be feasible if we don't continue getting additional funding. The documenting requirements are just through the roof. And so, it can lead to burnout. You really want to be doing direct patient care or making phone calls for housing or really working on delivering high quality medically tailored meals. And yet you have all of these documentation requirements. And, there is no such thing as a free lunch. So, if we're going to be getting that money from DHCS, they want to have, and our managed care plans want to make sure that, you're actually doing what we think you're doing and making a difference. Keeping up with requirements. One of our potential ECM providers, they're providing services, but they're not quite in line with the requirements. And so they have to figure out what the requirements are for documenting and this, that, and the other. The requirements for even implementing the CHW benefits has, had some people kind of steer away from that, which, unrelated, well, partially related. Preparing for potential audits. So, the managed care plans are going to come in and audit to make sure again that, you're doing what you say you're going to do. Clarifying like what's our workflow, like, who's doing what and how does it get to, the next stage. how do we keep our ear to the ground? Like I just look at those DHCS stakeholder updates. It's basically like a newsletter. They're nicely put together. It's not too much. I kind of look through and see what I need to know. And then ignore the stuff that's not relevant to me to the best that I can do. So if you're not a subscriber, you can always subscribe so that you too can have your ear to the ground. So we are reaching the end of our hour, and I've talked as fast as I can to get as much as I can in. I'm probably not taken as deep a dive as some people may like, but you know what? We have a lot of experts on this call. You know who you are, and I know who you are. We know who you are. So it's a little bit of preaching to the choir because you've probably heard a lot of this before. So thank you so much for those who were with us yesterday and completed our Zoom poll, because as you know, we really would like to kind of make sure that this was not a waste of your time. Number one, that you learned something new and that you let us know how we can get better, because truly, 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 that is how we improve. I did want to stop sharing for a second and kind of open it up in case there were if anyone wants to add any comments. Otherwise, I'm going to show you a couple of websites that may or may not be helpful. So any comments or questions? Karen, great comment. Thank you for describing the details. Daily operational details will make the difference for success with streamlining and standardization across everything. So you said it perfectly, Karen. You summarized a big chunk of what we talked about today. Thank you so much. That's perfect. So I am going to get those websites up to share with you. So this is the Alliance Provider Directory. So if you want to just kind of look, or you're curious, I go and I check this periodically because I like to see like who's on this list that's not a participant with the Path Collaborative. And I look over down here on this bottom right-hand side, there are 35. This was at one point over 40. So we've actually kind of lost a few. So I think that's interesting. I don't know whom we've, and I guess lost isn't the right. Some people are no longer providing community supports or ECM that were. But this is where I go to kind of look at who's providing what. And you can see that for community supports, there's a ton of information. So for Coastal Kids Home Care, for example, they are accepting new patients. We do have ECM providers who have closed to new referrals, whether there are any restrictions. It's very specific about services. And you can see for ECM, like you can't see what population of focus Coastal Kids Home Care provides services to. I really, really wish that one day this will change. This is a request that our ECM and community supports providers, especially our ECM providers, noted way back in January is, who's doing what in our county. And until we have that detail, which we actually, the Path Collaborative has tried to put together, this is really important information. And when we met with RF from Kaiser, we said, hey, if you are putting your provider directory together, can you make sure that you put the populations of focus on there? Right now, the Alliance has a hold on any enhancements to the website. So we have to give them a little grace. But this is also kind of the place to go for the Alliance, enhanced care management and community supports, as so many resources. I have no idea why the word ECM or the acronym ECM is highlighted blue on my browser. I've tried to fix it. I have no idea. It's not like I haven't searched on ECM, so I have no idea why it's like that. But anyway, there's so much here. And when you click on learn more, there are so many training videos, and they recently kind of cleaned them up so they're not quite as bewildering, but this is a place that I think as you're kind of onboarding new staff, like choose the 3 or so webinars that might be the most helpful for onboarding your staff so that you're not having to create these yourself. So you can see up here, there are ECM and community supports trainings. There are just a bazillion of them. I went through at one time and like earlier in the year and kind of tried to curate them and have a little bit of a description, but it was just a little bit too much. But you can see putting cultural humility into practice, safety in ECM. I mean, the topics are all over the place. In a good way. I mean, not like as in they're all over the place. And oh my gosh, I forgot to pause on slide 34. I had it all prepared, like I was gonna say dun da da da, drum roll. And I'm just remembering that I did not pause for our announcement, so I'm gonna turn it over to Berenice now.
Thank you, Trudy.
Thank you for the giggles.
And happy lunch hour, everyone. I see lots of familiar names, but for those of you who don't know me, Berenice Herrera Lopez, Operations and Program Manager at HIP. And yeah, we're just really excited to share with everyone that our PATH team at HIP will be expanding in 2024. So we have confirmed that we will have Stephanie Sonnenschein, a prior CEO of the Alliance, as an advisor to our team, specifically for PATH and other projects. And she will be kind of reviewing our work plan for 2024 and providing feedback and recommendations. She will be advising with content and delivery of that content for some of our regularly scheduled convenings. And yeah, we're just so excited with the amount of knowledge around CalAIM and Medi-Cal that she has, that she'll be able to really kind of guide our team in some of these areas where she's just an expert. And then HIP is also hiring for an operations and programs director who will spend a good amount of time on the PATH project as well and really helping us guide the work. So I'll put the link to the job description in the chat. Please do help us share widely, or if you have any recommendations in terms of who could apply for the role. And I think that was all. Thank you. I know we're right at time, so we haven't gone over yet.
Thank you, Berenice. Sorry. And we can, thank you so much, everyone. We hope we see you tomorrow. Really looking forward to tomorrow. Have a stupendous day. Thanks for spending lunch with us. Maria, let's stop our recording.